Good afternoon, ladies and gentlemen. I must apologize for the delayed start. I was hoping to get the videos working, but we'll put them on the website for you. So I thought I would change tact a little bit today, and instead of focusing on the basics, show you how these exciting technologies help us at the bedside and in the clinic in order to make a difference to our patients. So we're going to focus today's lecture mostly on the clinical applications for cardiac MRI, but I thought I would spend the first 3 to 4 minutes just recapping some of the important messages from yesterday. So you'll remember I started off showing you this slide and telling you how fortunate we are in cardiology that we have a number of both invasive and non-invasive imaging techniques. And I hope I stress the fact that these techniques are both complementary and should be used appropriately for the appropriate patient. And also highlighted that the non-invasive tests that we use routinely are these, and we're focusing in this series on echocardiography and CMR. I also mentioned that the technique of ultrasound or echocardiography is based on sound waves traveling to a point and being reflected back, and using fancy mathematics to convert changes in energy into the images that we get. Importantly, it's a non-invasive technique. It has no harm associated with it and doesn't use any ionizing radiation. I highlighted the advantages of ultrasound, including the wide availability, the portability, the lack of excessive expense, and the fact that it's safe and can be repeated as often as we need to, but also highlighted its limitations, particularly the operator dependence and those people with altered hemodynamics from medication or changes in body habitus. So my videos seem to play and then stop, and I was hoping to highlight a few important anatomical and functional points with ultrasonography. So this is a short axis view with the anterior and posterior mitral valve leaflets of a heart that is contracting normally. Let's see, may just need. So that's a normal heart on ultrasound. And a different view, parasternal long axis view, showing us the anterior and posterior mitral valve leaflets, and then the, sorry about this, the aortic valve leaflets are over there. And this is a 4-chamber view showing us the left and right sides of the heart, and the mitral and tricuspid valves opening and closing normally. And I was asked to show you a clip of the hemodynamics and the sounds that our hearts make during this assessment, but these refused to play. So MRI, on the other hand, is an altogether different technique from ultrasound. And as I highlighted, it's based on the body's intrinsic magnetic properties. Again, it is safe, it is non-invasive, and like ultrasound, has no ionizing radiation associated with it. I mentioned that one of the advantages of MRI is that in a single examination, we're able to measure a whole host of different parameters which give us very detailed information about the phenotype of the cardiovascular system, from gross anatomical and functional information to events happening inside different components of the cell. I highlighted the important advantages, like the high spatial and temporal resolution, the high accuracy compared to other imaging techniques, the fact that it's not user-dependent and it's very reproducible regardless of the user. And is very importantly able to allow us to be able to characterize tissues and to get information about the state of fibrosis or scarring, the state of inflammation, and the water content of the tissues, or what we refer to as edema. Of course, its drawbacks include its expense, the lack of wide availability, and lack of wide expertise, and in a small proportion of patients can be limited by claustrophobia. So the common indications I discussed yesterday, we use it for a number of conditions where it really is the gold standard imaging technique in the field of cardiology. And these are the different conditions that ideally we should image with this technique. And I hope to discuss some of these today and show you why this is a useful test. We also touched upon issues of safety and highlighted that when exposed to these constantly turned on magnets, whether we're imaging or not, the magnetic field can cause ferromagnetic particles to act as projectiles that may be very dangerous. And of course, it can affect a lot of devices that we use daily, from watches to cell phones to pacemakers and ICDs that many patients have. And so I'm going to show you some cases to highlight the clinical utility of this technique. And the first case I'd like to show you is that of a young man who presented with heart failure, so shortness of breath, with swelling of the legs, difficulty lying down flat. And he was investigated with a number of techniques, and the doctors were no closer to being able to confirm what his diagnosis was. And I think probably the history was not very well elicited, because the chatting to the patient, we had clues to what the likely cause of his heart failure was from his story, which was overlooked by the first set of doctors. So what this shows us, I'll keep on going backwards and forwards just to let the videos loop once. A big heart that is not contracting very well, and very dilated cardiac chambers. And again, very big cardiac chambers, both the ventricles and the atria. And one can appreciate how thin the walls of the ventricles are compared to what we normally expect. And in the short axis view, again, we can appreciate the markedly impaired contractile function of the heart. And you can appreciate an associated pericardial effusion or fluid around the heart, which is a common feature in patients with heart failure. And then we give contrast. And what the contrast shows us is that in this very thin wall of the left ventricle, I hope you can appreciate an even finer, thin line in the middle. You can also see it in this projection over here, and again in this four-chamber view. So when put together, these give us a conclusive diagnosis of dilated cardiomyopathy. Patient has a dilated heart which contracts poorly, and in fact has got a family history. He had an aunt and a brother who both had transplants for the same condition. And so we might have been able to make the diagnosis if the history had been taken properly. But with other imaging techniques that's showing a big heart and nothing else, the ability to gain all this additional information, and in particular, the classic pattern of enhancement on MRI, was able to clinch the diagnosis and allow us to be able to put him up for transplantation, and is now doing very well. So that's the first case I wanted to show you where this technique was able to make a difference. So the second picture I'm going to show you is again another young man, also with unexplained heart failure. And he had no preceding history. He ran marathons and had been completely well until he presented. And what you will see again is a big heart that contracts poorly but is very thin in this basal inferolateral part compared to the rest of the walls. And in fact, if you look at the movement of all the walls, the thin bit is also what seems to move the least. And we gave him what is called stir imaging, and this is a way of looking for edema or swelling in the muscle of the heart, and there wasn't any. But what we found was that on administration of contrast, he has a clear scar in the same part of the heart that was thinned and not moving well. And in this image, two-chamber view, it appears to take about 50% of the wall, but in these short axis views, actually is what we call transmural. The scar takes up the entire thickness of the wall, and this pattern of enhancement, which is clearly different from the initial pattern of enhancement I showed you in a patient presenting similarly, is compatible with a recent heart attack. So this is a young man who's had a myocardial infarct in the inferior wall of the heart. And while the doctors thought that a heart was highly unlikely given the normal appearance of the electrocardiogram and the young age of this patient, when they took the patient to the cath lab, they actually were able to confirm an occluded right coronary artery, confirming the diagnosis of a myocardial infarct or heart attack, and allowing the doctors to start the appropriate treatment and cardiac rehabilitation. So 2 presentations of heart failure in young men with 2 very different causes, and this technique allows us to be able to make the diagnosis reliably. I'm going to show you another young man who also presented with a big heart and heart failure, and the doctors again were uncertain what the underlying cause of the heart failure was. Again, he'd been previously well until this presentation. So again, you'll appreciate the markedly dilated heart compared to the 2 hearts we've seen, again with very thin walls, a normal appearing right side of the heart with normal function of the right side. So the pathology is limited to the left side. The other thing I hope you'll be able to appreciate is that the left atrium, this chamber over here, is markedly dilated, and that the valve between the left ventricle and the left atrium is leaking quite a lot, what we call mitral regurgitation. So you can see the leakage there, which is quite severe. Yeah. So if I move to a different image. Again, you can appreciate let's start with this image here at the top. I must apologize, I'll keep going backwards and forwards. You can see the dilated chambers and the leakage, and here, poor contraction, but now a striking finding, which we haven't seen before, of the layer of myocardium, instead of being one compact layer as you expect, has a thin compact layer and a non-compacted layer. And this allows us to be able to confirm the diagnosis of left ventricular non-compaction, which is a condition of the heart where in the embryological stage of development between 21 and 34 weeks of gestation, where the developing heart goes from a bud and is able to form a heart with 4 chambers with the appearance that we know it to have. In a small proportion of people, you get embryological arrest of the compaction of the layers of the heart, and in adulthood causes the heart to be weak, to contract poorly, and they present with heart failure as well as clot formation because of the slow flowing blood trapped in these trabeculae and forms clots, which can then result in strokes and other complications. And so we're able to confirm the diagnosis of left ventricular non-compaction in this young patient, which was also confirmed genetically, and he was put on the appropriate treatment. So now I've shown you 3 young men presenting with heart failure from 3 very different causes, requiring 3 different approaches to management, and we're not able to confirm the diagnosis by any other technique. I'm going to move away from heart failure and show you a woman who was 44 years old who presented with chest pain, and there was really no other symptom, and the doctors thought that the likelihood of this woman having atherosclerotic heart disease that would result in ischemic heart disease, what causes heart attacks, was highly unlikely. But they went ahead and did a coronary angiogram anyway, and her coronary arteries were pristine, so with no evidence of blockage of the coronary vessel. And so they were scratching their heads as to what can be a cause of chest pain in a young person without any risk factors for coronary artery disease. So you can appreciate the markedly thickened wall, hypercontractility of the heart, and if I go back, you'll also see that there is obstruction of the left ventricular outflow tract. So the combination of these findings points conclusively to a diagnosis of hypertrophic cardiomyopathy, which is a different form of heart muscle disease and is in fact the most common hereditary form of heart disease, with a prevalence of 1 in 500, so very common. And in most people, it doesn't cause any symptoms, so people walk around without any awareness, but some people may present with chest pain or breathlessness, and in young men who participate in sport is the commonest cause of sudden cardiac death. So again, very thickened heart muscle with obstruction to flow in the left ventricular outflow tract. And when we give contrast, you expect the blood pool to be gray and the muscle of the heart to be black. And what you see here is that there's a lot of white where there should be black, and that is all scar in the muscle of the heart. And this is what predisposes to the development of abnormal conduction in the heart, giving rise to what we call arrhythmias, some of which may be very serious and precipitate premature death in these patients. So a patient had a very thickened muscle of the wall with lots of fibrosis, with a very narrow left ventricular outflow tract. And in fact, when the heart contracts with occlusion of flow there, and the gradient was very high across, and the combination of all these factors meant that her risk of dying suddenly was in the high range, and she had an ICD put in. ICD stands for implantable cardioverter defibrillator, so that if she has a dangerous heart rhythm developing as a result of the scar and the hemodynamic abnormalities that result from a condition, it would shock her and get her back to a normal and healthy rhythm. So again, to highlight the important features: thickened heart muscle, obstruction of the outflow, dilated left atrium, and again, lots of scar in the muscle of the heart, confirming the condition of obstructive hypertrophic cardiomyopathy. So, a different case now. This is a patient I scanned recently, a young man who presented to us with a condition known as tetralogy of Fallot. Tetralogy of Fallot is a clinical combination of abnormalities in the heart, which is usually diagnosed early in childhood. And the gentleman who first described this was a French physician practicing in the early 1800s in Paris. And he found that in some children, they have what we call a ventricular septal defect. In other words, in the wall between the right and left ventricles, there is a communication, and that the aorta, which is the main blood vessel coming out of the heart, instead of coming from the left side of the heart as you expect, it actually straddles both the right and left sides of the heart, and we refer to that as an overriding aorta. And that these patients have got obstruction to flow in the outflow of the right side of the heart, and as a consequence get thickening or hypertrophy of the muscle of the right side of the heart. So this is a patient who had tetralogy of Fallot, which was diagnosed at Red Cross Children's Hospital. The patient had the appropriate surgery, which is a closing of the VSD, the ventricular septal defect. That's the VSD patch. And you can appreciate that the aorta, instead of coming off the outflow of the left ventricle, straddles both the left and right ventricles. And patient was now complaining of shortness of breath and chest pain, but he was 27 years old, and the doctors looking after him thought it's highly unlikely that he could have had a dangerous cause of chest pain. But just to be on the safe side, they would send him to us to check. And what we found was a markedly dilated right ventricle, which doesn't contract very well, but a normal appearing left side of the heart. I won't play this cine, but the reason I put this in here is to show you that even on the cine imaging, one can appreciate thinning of the apex of the heart, as well as a filling defect sitting towards the apex of the heart, and that is thrombus, a clot. Okay? And again, the left side of the heart and a markedly dilated or enlarged right side of the heart. Left side of the heart, markedly dilated right side of the heart. And when we do the flow imaging, it won't play. Okay? And when we give contrast, one can appreciate the scar at the apex. So this young man had a clot in his heart, which probably broke off and entered his coronary system, causing him to have an embolic heart attack, of the apex of the heart. So this imaging was again very useful because it guided us to the correct diagnosis and allowed the doctors to be able to take his condition seriously and to treat him as somebody with a heart attack. Otherwise, he would not have had the appropriate treatment. So I'm going to move to a different case. So this is a different patient. Again, a young girl who presented with shortness of breath, and when they did an ultrasound scan of the heart, the doctors found a defect in the wall between the right and left sides of the heart, what we call a VSD, or ventricular septal defect. And they didn't see anything else, and wanted more information before they decide to operate on the patient. And what they did not appreciate was that the patient effectively has got a single heart chamber. This is the defect between the two chambers, a vestigial left ventricle and a right ventricle that works as the systemic ventricle, and only a single atrium instead of two atria. The patient has only got one atrium, and instead of two valves between the ventricles and the atria, you have a single valve. So this is what we call a univentricular heart, so a heart that works with one chamber in the ventricles and one chamber in the atria. It's a very uncommon congenital form of heart disease, and a single atrioventricular valve, which I hope you can appreciate is leaking severely. You can see the leak, and again in this view you can appreciate the blood flowing backwards. And as though that combination was not bad enough, she also did not have pulmonary arteries, and the blood coming out of the right ventricle ended abruptly with no outflow, and so could only come out of the left ventricle. And in order for blood to return from the body into the heart, you had what are called MEPGAs, which are connections through these very dilated blood vessels through the lungs to enter the heart. And you can see some of them here entering the heart. So very complex congenital heart disease, where the diagnosis probably would have been missed by other imaging techniques, and where the doctors had planned to perform an operation to close off the VSD, were actually able to convince them that the existence of that defect between the right and left sides of the heart was what was keeping her alive, and so it was not in her interest to have the corrective surgery. So this is a young patient again who presented with heart failure from childhood and had been followed up at another hospital for over a decade. And because he had heart failure and he had what we call Q waves on ECG, which is an indicator of usually associated with a previous heart attack, they labeled him as somebody with a dilated cardiomyopathy and never questioned the Q waves, but he was only found recently to have severe aortic stenosis. And so the reason he was referred to us was not to question what they thought was a clear-cut diagnosis of dilated cardiomyopathy, but to question the stenosis or narrowing of the valve. So you can see a big heart which contracts poorly, and there is an effusion around it, a collection of fluid, and again fragmentation of the heart muscle with both a non-compact and a compact layer. So we already know that he's got a big heart and he's got left ventricular non-compaction, which was not diagnosed. And what one can appreciate is that he's got severe narrowing of the aortic valve. But I hope that you can also appreciate in this view, this is at the top, the pulmonary artery, which connects the right ventricle of the heart to the lungs, and at the bottom, the ventricles which contract, that there is this connection between the ventricles and the pulmonary artery. And so, in fact, this patient, again, you can appreciate the very narrowed aortic valve. And the reason it's narrowed in this young patient is because he had a bicuspid, only 2 cusps instead of the standard 3 cusps. And when we give contrast, one can appreciate that the pattern of scarring is compatible with a previous heart attack and is not due to a dilated cardiomyopathy. So we're able to change his diagnosis to demonstrate that he's had a previous heart attack, probably in the first few months of life, and this has been missed all along. And in fact, the reason he's had a heart attack was because his left anterior descending coronary artery doesn't come from the aorta, which is the main blood vessel, but comes from the pulmonary artery and takes a dangerous course between the pulmonary artery and the rest of the heart. And so when the heart contracts, that vessel is constantly being squeezed because it's being pushed against the pulmonary artery by the contracting heart. And when there is lack of blood flow, his heart doesn't get any oxygen and nutrients, and so kept on dying bit by bit. And so we're able to offer him surgery to preserve the rest of his myocardium. And again, would not have been able to make this diagnosis without this kind of imaging. So this is another patient who has a defect between both the 2 ventricles and the 2 atria, and had what we call an atrioventricular septal defect. So the septum, or the wall between the 2 atria and between the 2 ventricles, was missing. And the other finding was that this patient had markedly enlarged pulmonary arteries as well as the branches into the right and left pulmonary arteries. And again, a markedly dilated right ventricle. And what this confirmed was that this patient, who the doctors thought that he only had a defect between the 2 ventricular chambers, had actually had long-standing shunting of blood from the left side to the right side, such that the pressures on the right side had become so high that the blood was now being shunted from the right to the left, a condition we call Eisenmenger syndrome. And again, this is a condition that cannot be treated surgically or corrected, and if you do, you compromise the patient. And then I think this is the last case I want to show you where we take pretty pictures in a young man presenting with chest pain and heart failure. You can see a big left side of the heart, a big right side of the heart. You can also appreciate a big collection of fluid around the heart. And if this were to play, you would appreciate that it contracts very poorly. When we give contrast, you can see that there is scarring in the septum or wall between the left and right sides of the heart. And when we use parametric mapping, we're able to appreciate a very high signal intensity indicating the presence of very marked inflammation in the heart and very high water content or edema. So this is a patient who's had a recent acute injury of the muscle of the heart with formation of scarring as a result of necrosis of the heart and a collection of fluid around the heart. And again, when we give contrast, one can appreciate that the scarring is not just in the middle of the heart, but also in this lateral wall of the heart, there as well, and again there as well. And when we give different tissue characterizing sequences with MRI, you can appreciate the very high signal intensity. In other words, lots of edema, water content in this thickened and swollen heart muscle. And again, lots of swelling and inflammation with scarring, as I've shown you previously. This confirmed the diagnosis of myocarditis, which in the past you could only make on heart biopsy, where you had to perform a dangerous procedure where you put biotomes, which take a chunk of the heart muscle, and then you look under the microscope and confirm that this is inflamed tissue. But now we can make the diagnosis very confidently using these non-invasive techniques without exposing our patients to any of the dangers of having to take tissue to confirm the diagnosis. So, ladies and gentlemen, I must apologize that my videos would not play, but I hope that I've given you a sound introduction to the basics of cardiovascular imaging, and hopefully you will leave after these 2 days with some understanding of the mechanics of two of the commonly used techniques for imaging in the form of ultrasound and MRI. And I hope I've shown you how these techniques allow us to be able to fine-tune our ability to make the correct diagnosis, but importantly, to be able to manage our patients appropriately in a way we haven't been able to previously. And I hope that you will sense not only my joy, but we will also leave with excitement and an appreciation of the role and impact that these pretty pictures I look at every day have on improving and maintaining the well-being of our fellow human beings. I thank you very much for your attention, and I'll turn on the lights and be happy to take any questions you may have.
Screening process for supposedly healthy people ahead of something happening?
So that's an excellent question, and there is such a thing which is a review by usually a family practitioner or GP, and the two important skills they can use to screen for heart disease, which a lot of people don't put much value on these days because of the availability of such expensive tests, is the ability to talk to your patient and the ability to touch your patient. And those are two powerful screening techniques. And in fact, in the vast majority of people, when used appropriately, they allow us to be able to stratify with a high degree of finesse who is likely to develop heart disease and who is likely to remain healthy. And one can use, of course, a whole host of imaging and ECG-based or other cardiovascular techniques, but in the absence of a clear indication and where the a priori risk of a condition being present, their utility is very limited and in fact may erroneously lead to incorrect diagnosis and a heightened sense of anxiety in our patients because of results that may not be true. So I emphasize to my students all the time that while we may have access to these very fancy techniques, one can never overstate the importance of still talking to one's patient and touching one's patient to examine them and to be able to assess the risk of disease and, importantly, the presence of disease where it is present.
On a related note, though, I totally understand what you're saying about the population at large, but after somebody has survived one heart attack, isn't there value in actually assessing exactly the damage that's been done to the heart so that the person going forward has a good medical history?
I could not agree more. So there are different kinds of screening. What I was talking about is primary prevention screening, where you're looking at a population of asymptomatic people who may be at risk of developing a condition and being able to use your clinical assessment to stratify the risk. But once somebody has had a condition or care or has the presence of risk factors, then one does what is called secondary prevention to be able to assess how severe the condition is, how much damage has occurred to the muscle of the heart, and what is the likely prognosis of the patient. And this is when many patients are referred to us to use these techniques. So in fact, most of the patients I showed you today fall into precisely the category that you described. A lady at the back, and then another question here at the front.
What can you do about the thickening of the heart, the aorta, and other organs?
It depends on what the underlying cause is. So in all of us, from the age of about 25 years old, our arteries begin to stiffen, they begin to thicken. And as they thicken more and stiffen more, the risk of developing adverse cardiovascular outcomes increases in proportion to the degree of stiffening and thickening. And so one could argue that all of us in this room are probably beyond our peak from the 20s. And we can use a number of non-invasive tests to be able to diagnose and to monitor the thickening of the blood vessels. And in the vast majority of people, they never thicken enough or stiffen badly enough for us to do anything. We can put people on certain medications like statins and blood thinners like aspirin, which decrease both the risk of clot formation and the risk of deposition of fat within the wall of these blood vessels. But once the thickening is severe enough, there are a number of both minimally invasive percutaneous techniques to keep them open, or surgery where we open them up to either remove the diseased part and put in a prosthetic graft. People these days mostly use stents, which you can put in either from the leg or from the arm, and the patient goes home the same day. As with everything we do in medicine, there's